guys hear me? Can you guys hear me okay?
You were loud and clear.
You're not hearing me?
We can hear you just fine.
Oh, someone was, you were ribbing me on that one, weren't you? I started looking at all my buttons. I'm thinking, what am I doing? Oh, okay. Well, thanks everybody for joining us. This is our last Bureau meeting of the day. Following our agenda, we're next going to be looking at our attendance report. If Shelley, if you'd be willing to display that. PACES is not a statutory committee, but we do have a valuable service that we do for the Bureau, particularly advising the statutory meetings. Like the other committees, we like to encourage a full attendance and we need quorum to meet. So for that reason, we do track attendance. It's an open meeting, but we do have voting members, as you see listed there. If you miss more than 2 meetings, Shelley's going to reach out to you and confirm that you want to stay on the committee. And that's just so we can always have a regular presence and regular input from our experts that are named to the committee. So Shelley just displayed that, and we appreciate everybody. We have Ray Proa in the call. We have a new council member.
Yeah, Dr. Woolridge, I'm here.
Oh, wonderful. Well, thank you so much. Ray is going to be filling our paramedic role as far as the designated PACES committee member paramedic position. And Ray, we really appreciate you joining us and look forward to working with you. Ray, do you want to say a couple words, introduce yourself?
Yeah, definitely. I've been following the PACES committee for a little bit, but yeah, my name is Ray Proa. I'm the Division Chief of EMS with Fort Mojave Mesa Fire over in the tri-state area in the Western region. Been in the fire service about 19 years, been a paramedic for about 16 of it. Worked here also worked in Las Vegas Fire and Rescue. Now here's the Division Chief of Fort Mojave Mesa Fire, and also serve on the TEPI committee, and really happy to be here and contribute.
Well, great to have you on board. Look forward to meeting you in person sometime.
Yep.
Okay. Next on the agenda is the Bureau reports. Do we have Chief Garcia in attendance?
Good afternoon, Dr. Woolridge. Some real quick updates are that we have new Bureau staff that have joined us recently. We have Licia Castro, a new project coordinator senior, who's going to be helping us with implementing a new image trend licensing management system. We'll be using the committee meetings and regional councils to provide updates on any of the new system implementation moving forward. Some more to come on that. We covered quite a bit of ground today with 3 other committees that met this morning. In the interest of time, we are sharing that with legislative session just wrapping up, we will be coming back to EMS Council in September to provide some updates on legislation and some rule updates that will follow as a result of some of the new EMS legislation here in Arizona. If this group has not subscribed to our Gov Delivery already, we do recommend that you please sign up for Gov Delivery updates. That is the forum where we push out email updates on any state and national information that we want to keep everybody in the state updated on. So we will be communicating that way between now and the next round of meetings. I will also share that thanks to Chief Proa, who's on the line as our new member of PACES, we have been talking a bit about hand-heavy and how that is used throughout the state. We traveled to the Western region in the last couple months and learned a little bit about its use currently. It has been shared with us that there are over 60 agencies currently in the state of Arizona that are using hand-heavy. And we are looking forward to learning more about it. At this stage, we don't know a whole lot. Typically, our procurement teams here at the state or with any of the individual agencies do handle that sort of thing when it comes to contracts for something like hand heavy. So at this point, we would recommend anybody that's interested in hands heavy, if you do not already have that resource available to your agency, please reach out to your regional councils and let them know if that is something that your agency might be interested in. And I will just say we look forward to learning more. That is all I have for now. I will turn it back to you, Dr. Woolridge.
Thank you, Chief. Appreciate it. Adam, would you be so kind to do the regional update on the regional contracts?
Sure. We are just getting them out the door. We have updated a portion of it to include some verbiage, and we just took it a step further to include the title Pediatric Emergency Care Coordinator in there. The previous contracts contained verbiage that was pediatric oriented, but we just took it one step further to give them give the opportunity to take that designation as a regional functionality as it's described, as that position is described by NEDARC and EIIC. And so if each region over some period of time could identify an enthusiastic person that would like to champion their pediatric training and education, that person will serve as a conduit for me to push out some of the information that I get from my various sources out to your EMS regions the way you see fit, or however you might do that. So I don't think it's a lot to ask for one person from each region, and then what I would require of that person is to turn around and gather some base of distribution in turn. So we can hopefully get those contracts out if you haven't already gotten them, and then get some names turned in, and we can kind of get going on that. Otherwise, that's what I have for that, Dr. Woolridge.
Yeah, if you would, for all those in attendance, please share with your own agencies and your own regions, colleagues, etc. Adam is our coordinator for the EMSC State Partnership Grant, and that's how a lot of how national EMSC efforts funnel through to the state. Let alone that grant has money for educational purposes through the region. So it really benefits Adam in his role to have that liaison contact, not only with the regions, but even individual agencies. And promoted centrally through MSC is that the fact that having a pediatric champion really adds to an individual agency and individual region having robust pediatric services. So this is what we want to promote, communicate it out. That champion can be anyone. Champion can be a shared role, between individuals at an agency. So it's really, as Adam had said, having that liaison available to us. So
thanks for that.
Great, thank you so much, Adam. Our next agenda is to discuss action items. Shelley, if you'd be so kind. Yep, these are our minutes. Can I have a motion to review our past minutes?
Mr. Dana Carpenter, I'll motion.
Thank you. In a second.
This is Ann, I second.
Thank you, Ann. Okay, and as Shelley scrolls through them. Pretty brief. Does anyone have any edits to the meetings? These are our March meetings minutes. Does anyone have any edits? Without any edits or comments, I would ask that we approve these. Can I have a motion to approve?
This is Ann. I motion to approve the minutes.
Thank you, Ann. Second?
This is Tony. I'll second that.
Thank you, Tony. Okay, excellent. Okay. And Adam, would you like to take 6B, behavioral health emergencies? Would you like to lead us on that, Adam?
Oh, Dr. Woolridge, sorry, the parliamentary procedure. Can you call for the vote for approval?
Oh, goodness, I'm sorry. Forgive me, everybody. Okay, so I think we'll vote for approval. Let's make it verbal at this point. Everybody in favor to approve, say aye.
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 Anyone in opposition, say nay. And do we have anybody abstention? Okay, I think that is approval based on the audio input.
Thank you. Sorry about that. Okay, so the next item is a proposed training that came out of the PACES Behavioral Health Work Group in response to the Arizona short report that showed an increase in behavioral health emergencies amongst all populations, but specifically amongst pediatric populations. And so this was kind of a quick sort of knee-jerk slide set to help pre-hospital providers navigate those challenges. And so a couple of the members within the work group were very pleased with it and said that it might be something that would be very valuable to them. And so we thought we'd bring it in front of all of PACES for your input about edits or additions. Specifically, you'll see in there a couple of asks. For example, on slide number 7, I think it is, it says transport at the top. Maybe it's not slide 7, but it says transport at the top.
Medications come up.
Oh, sorry. Oh yeah, some of these medications, and Dr. Ward, you had gotten back to me with the fact that these medications are many and variable. And so, from my point of view, I was thinking, how in the pre-hospital setting, it's pretty common that we'll gain a bit of a history from a patient's medications. Maybe if they're a poor historian or unable to speak, and so that was the motivation for this. But given the fact that you said that there is so many different types of medications that are, so what would you like to do with that?
Well, I mean, this is a collective decision, but my advice was to actually lose this slide. In that, and Adam you just alluded to, there are a ton of medications that could potentially be used. They're age specific. The atypical antipsychotics tend to be used in kids, for example. And when you list a medicine, where do you stop? Is it side effects, treatment, is dosing? Typically our patient will have past history and our medication profile that the pre-hospital individual will be able to access. And it's not a medicine we carry in our rig anyways very often, other than traditional anxiolysis like benzodiazepines. So my advice was to not have this slide. Similarly, the other comment I had made, if you scroll up a little bit, and this is just general bookkeeping, when we create a resource, and we post it, and it's available for EMS agencies across the state. But that EMS agency may pull one slide, they may pull 3 of them. They may not use the whole slide in its total. So my other suggestion was is in referencing each, anything that's referenced should be contained in that slide. So for example, this one here, background. Adam has a slide of references at the end of the slide set. But what if an agency just wanted to pull this one slide? So that superscript 2 probably should have the hypertext linked at the bottom so that it's contained within the slide. So that was the other suggestion that I had. And I'll stop there so other people can comment.
Did you mean a hypertext or a hyperlink on that superscript to what exactly? I'm sorry.
To the reference material.
Oh, gotcha.
Yeah. Okay. So if you would, Adam, go ahead and scroll to the end to your reference slide, because you have all the. Yeah, one more. Yeah, there you go. So you have it all referenced out, right? But what if an agency pulled your one slide but didn't include this slide? So my suggestion would be to put the hypertext in small font at the bottom of the slide itself.
Oh, okay. Yeah, I see that.
That's just bookkeeping. So I don't know if the rest of the group has had a chance to review this in advance of this meeting. It was in the agenda, but I would open the mic for anybody else who had comment.
Your other ask to transport line.
Did you want to go back to that transport slide?
Sure. Yeah. So one of the specific asks to the region is on this transport slide, and what I was kind of hoping with for this was to make it sort of region specific. And so it's a sort of a roundabout way of asking each region about any local resource, any regional resource that they're just aware of because you're operators in your first due that maybe we're not catching, and that we're trying to cast a net that catches all of the behavioral health resources, moreover the pediatric behavioral health resources that are available in the state. And it's a good place to start to go to the first responders to ask, what is it are you aware of that's in your community that can be added to this so we can make it a little more useful and regional specific. And so if you can't, if nothing comes to mind immediately, that's perfectly fine. I'll put my email in the chat, or you can reference my email at the end of this slide set to absolutely send me some follow-on items that we can amend in here.
Ooh, you know, this is a tough one because this one alludes to a refusal of care, treat and refer, clearing the scenes without transporting. EMS agency reimbursement is often through transporting, unless they have a ability to treat and refer. Similarly, in the education committee earlier today, one person who brought up, I thought, something that was a very sensitive topic, in that smaller communities don't have pediatric behavioral health facilities to transport. In our behavioral groups breakout meeting, we had talked about, you know, what are our alternative opportunities for that EMS agency who encounters a minor with a behavioral health crisis. Right now, we're stuck with transporting the DED, which is not always an optimal solution for that individual. And I think, Adam, if I'm, you know, not to speak for you, but I think what you're alluding to in this slide is what are our alternatives? Could there be crisis resolution? Could there be guardianship, transport to a level 2? Are there even level 2s in the community? And yeah, this is a tough one. Comments from the group, please.
So some of the feedback we did get from one of our more rural medical directors was that they do not have any other resources. So these patients are all going to go to the emergency department as the only resource in their area. So I think outside of likely Maricopa and Pima County, it sounds like the majority of these patients are going to go to the emergency department as their only resource.
And that's the motivation behind this slide set was the original item that propelled this forward was that children are sitting in EDs for an exorbitant amount of time, and so yeah, I completely agree with you. It's all aimed at a reduction of that, but it's such a large thing to chew on.
And I would venture to say that even in Maricopa County, based on just the geographic spread of facilities, EMS is typically going to go to their closest ED anyhow, because you may certainly end up driving an hour and a half to get to a quote pediatric facility, and those patients may end up getting transferred anyhow because the determination for an inpatient bed is based on diagnosis, patient care needs, patient age, insurance status, as well as bed availability. So it's so multifactorial, but I don't know that I would necessarily encourage people to bypass their closest facility, knowing full well that these patients often in the pediatric population sit and hold in the ED for 22 weeks. But I don't know that bypassing other facilities is going to necessarily change that outcome.
I concur with Dr. Bradley. I think there's this perception that PCH admits a lot of biobehavioral patients, and we don't. We have very limited beds. Many of our, biobehavioral evaluations done by social work or CPS, Child Protective Services, is done remotely anyway. So I agree with her that they should probably go to their closest facility because most EDs can do what we're doing already.
Let me ask the group, does it ever occur where an EMS agency will identify on the scene that there is not a crisis and divert to the guardians for subsequent management? And in that scenario, if that occurs to any degree, and they clear a scene, then a slide here would be, to essentially specify risk of self, risk to others, SI, HI, etc. Transport is our only option. But if they never clear scene anyways, it's really a moot point, and this slide shouldn't even be there.
So just to clarify the question, is there ever a chance in a situation where a parent or guardian may take the child directly to behavioral health resource as opposed to EMS? Was that the question?
Yes, yeah. So the guardian essentially refused transport and essentially says, I will take my child to the counselor. I will take my child to the clinic. And does, I don't know if we necessarily have data on that, but I mean, if that is a percent number of events, then we could essentially have a triage, a two-option scenario here when it comes to transport. But if it never happens, transport is always to the D, right?
I would say for the vast majority of pediatric patients where 911 is called, there's usually more of an acute or urgent intervention needed. So typically, the child is either voice suicidal or homicidal ideation, there's significant behavioral outbursts, or some attempted self-harm. There are some rare cases where I am aware EMS has had a patient that was not SI or HI, there was no intended ingestion, and parents felt comfortable transporting. In that case, the crew still felt like they wanted to call for medical direction just to cover themselves because it was so rare. So I think it's such an unusual circumstance. Is it possible? Yes, but I think it's probably less frequent.
I concur with
Dr.
that.
Bradley, this is Sandy. I think you're right. I know in Pinal County we have a lot of pediatric behavioral health patients, and very rarely when the crews respond, they typically will transport because there really isn't anywhere else for the family to take the child. And again, it can be a high risk, especially if it's suicidal or homicidal.
And I would say, off the top of my head, 8 out of 10 patients that are coming for biobehavioral reasons had to have medical clearance anyway, whether it's like superficial lacerations or an alleged overdose. The vast majority have to go to the ER before they are attached to biobehavioral services.
I agree with Chris. They mostly have to have medical clearance.
Yeah. This is Ray Pro. I'm over here in the Western regions. We're all super rural here. We will be, I can say that majority of these are going to be transported to the ER. And the reason why is because any kind of definitive like behavioral care, honestly, for closest is actually going to be out of state. So there's going to be phone calls and interfacility paperwork and things like that that are going to have to be set up. And actually, I've taken it myself to where I believe it's 7 leaves is in the Vegas Valley. And then other than that, then we're going to Phoenix. So now we're looking at like a 4.5 hour one-way transport being on that one. So yeah, it's just we don't have the resources here in the Western region for this. So this is definitely kind of a, even not just peds, but also adults. It's a huge issue over in my region to the point where, like I said, even at one point during COVID, we were taking psychs, peds and adults to Tucson. So there's just, it's one of those hard ones over here.
Yeah, and this is Heather Miller. I echo Ray on the Western region over here. The other thing that we're having issues with pediatric transport patients is if they are COVID positive, very few people are taking a COVID positive pediatric behavioral health patient. Most of the time we're ending up discharging these patients back to parents because we can't get them placed after over a week of having them in our ERs.
So this is not a voting item. We're reviewing the content. Adam, please let us know your intent on how you want to go through the next edition. But based upon what everybody's telling me is that this slide is probably going to be a strike through. Not to say we can't say something about transport,
That's what I thought. I mean, it's just focusing on the slide set. I think it would be beneficial to remove this just because there's so much. It seems to be the core of the problem, but removing it, I think, would allow us to still further educate providers out there. And so it may not solve the problem, but it's, I mean, giving our pre-hospital providers more equipment to recognize these things is at least a step in the right direction, even though it may not be a comprehensive solution.
Yeah, maybe consider changing the slide to transport considerations.
Sure, okay.
Have a couple of bullets that would be maybe advisory to the individual who's going through the module.
Okay.
And then we'll bring it back to the group.
Sure. Okay, regarding any other slides, any input immediately, or if you want to meet with me offline or whatever, send me something else offline, that's fine too.
Adam, I was gonna comment on this, and I'll be brief. So I know I could talk to online, and I know that Tracy met with you from here. But one of the things that I think is really important for EMS to understand is medication reconciliation. Oftentimes, especially if they're coming from far out, families don't come with them, and in order for them to be admitted for inpatient, they really have to have, medication reconciliation. So get an accurate medication dosages and how often it's given is really, really important for continuum of care.
Okay, as an addition to, where would you like to see that? I do hear that point.
Yeah, I don't necessarily know, and again, I apologize, I should have been involved with this more from the beginning, but I would say in general, that's something that we really see. EMS just kind of thinks that the family will bring the medications or the kid knows their medications, and it really.
Okay, all right. So you're seeing the lack of providing that child's complete medication history, and then they may not be bringing those medications in with them because do they assume they're coming to a hospital and that you'll have everything essentially?
Yeah, especially kids within our system, but oftentimes they're seeing outpatient psychiatric services, and so they're changing the medication. It's best for patient care, but it gets them admitted faster in inpatient services. We can reconcile their medications right away. Oftentimes they're calling their pharmacy, dispensing pharmacy and things like that, but this can be hang-ups with trying to get them admitted.
Okay, I totally hear that point. Let me see if I can work that in there. Thanks for that, Chris. Dr. Woolridge?
Might I suggest if we do change that transport slide to transport considerations, then this is one of those bullet points under transport considerations.
Sure.
Get a full medication list prior to departure from the scene.
Very good idea, yeah.
Yeah, great ideas. Perfect.
Okay. Yeah, thanks for that, Chris. Okay. Any other comments or mentions? Otherwise, you can send me what you got for us.
Yeah, again, this is not a voting item. We're building this module, so we can expand to certain elements. So please reach to Adam offline and send him your edits and how you would want to modify it. And the approach is what kind of module would my agency like to see? And then we'll build it as such. Anything further on that, Adam?
No, sir.
Would you like to take over the next one, Adam?
Sure. So I decided to include the creation, discussion, amendment of work groups in this because I very much believe that our intention is well-meaning behind the formation of work groups. Something that I've noticed is that the execution of those work, and this is largely on me, the execution of those work groups isn't as productive as they could be. And so one of the thoughts I had was to bring the work groups in front of PACES for the discussion of the certain topics, identifying training gaps with respect to this exact item that we're talking about. And what I'm hope to do with that is instead of put all of the work on the work groups, maybe we can shoulder some of the idea load here, and then the work group can actually be used to produce that item. And so that's sort of the motivation behind item C. And then these 3 training topics are just some of the ones I pulled off the minutes from our last training gap meeting. And so, for example, Tony had mentioned seizures in the last meeting as a need for a potential item for a training gap, an item as a training gap topic. I went ahead and looked around to see if we might be duplicating efforts here, and there is a couple of resources, not necessarily on the ADHS website for seizures specifically, but there are online resources that do exist that are very good with respect to these couple of topics. And so that's what I'm asking. What kind of things should we be looking at in the training gap work group? What are some of the actionable objectives? What do you all think? And these aren't seizures, pediatric patients with special needs and abuse and neglect are excellent topics. I definitely think we need one, some sort of continuing education for abuse and neglect.
If I may, on the seizure topic, Arizona was one of the study sites for the Rampart study, which was a very well randomized controlled study regarding EMS treatment for seizures in both adult and pediatric patients. And so I would just kind of ask this group that if the group were to tackle a seizure training, that this really be done in conjunction with the education committee, so that we make sure this is in line with the TTCGs and kind of the evidence-based literature that was done partially here in Arizona. So specific to the seizure one, I think that one has a little bit more overlap with the education committee. I would also ask just again to potentially solicit members from education committee to help with some of these other items, just because all these topics need to go to that committee as well. So I think if you have some cross-pollination up front, you can get some benefit. That committee does quite a bit of work on training curriculums. I think we're up to almost 20 PowerPoints now, so they do quite a bit of work. So I think that may help the process.
Chris Ramos is our cross-pollinator.
Yes, but I think in terms of people from the actual education committee also working on the subgroups. So yes, so people that would actually be helping to create this. I think what Adam is now kind of fully saying, and I will take the liberty of saying on his behalf, is there's a lot of interest in often developing training, but not necessarily the participation in the actual process. And so that's really where we need participation. And so we understand that everyone is volunteering their time, but we don't want to keep forming work groups if we're not getting participation from the members. So it's perfectly okay to hold, and it's also okay to say, let's potentially work with the education committee. For this group's awareness, there are going to be some pretty big topics coming up. If anyone has an interest, probably one of the more interesting updates will be the American College of Surgeons did publish their updates to the triage treatment and transport guidelines. So this is what kind of decides where trauma patients go, and there's some very specific pediatric changes in that. So if anyone in this group is interested, we can certainly help connect you with that work group in terms of creating education for EMS on that. So just some things to think about. We definitely would like to put out more pediatric specific training. We want to make sure that the education committee includes pediatric topics and criteria, but we also don't want to just form work groups if there isn't participation.
Well, may I suggest, and I was going to suggest you, Chris. So I don't know, you're about to say the same thing, but Chris Ramos is our PACES representative for the education committee. Would it be a good next step for maybe Chris, if you would be willing to reach to them and then kind of come back to us in PACES and give us our marching orders so we can coordinate those efforts?
Absolutely. And Dr. Augenstein and I already teach on seizures. That's something that would really emphasize. Not only is it one of the top 3 or 4 reasons in BEMSTS why EMS is activated for kids, but that's something that EMS really struggles with, not only in our region but throughout the country. So I could definitely help with that. And then I know this is throwing in more work, but the topic of pediatric intubation I don't think is going away, and I think it's a greater topic. But I would like to introduce that topic, and I could definitely be involved. Like I said, we've already done a lot of training on this. We teach every other week on this. So, and yes, Dr. Woolridge, I'll do that with the education committee.
Okay. And Chris, if you wouldn't mind, number 3, that abuse neglect concept. I have a lot of material on that. So if that's something they're interested in, I think that's somewhere we can help too.
Just to be clear, the ask is I go to the education committee and ask what they would like us to do at this committee, correct?
Dr. Bradley, that's kind of what you're alluding to, correct?
With respect to seizures, it was specific with respect to seizures with a larger idea of not duplicating efforts. So if we were to choose seizures, we want to make sure that we weren't stepping on anybody's toes.
I think making sure we work with the education committee specifically on that one, because Arizona was such a big part of the evidence-based guideline development nationally.
But it certainly wouldn't hurt to reach across and see if we were considering a topic to see if they had any sort of ammunition with that topic. And then Chris, to your point, yeah, I agree with you. When we did the workforce assessment, one of the topics, well, the top topic that came back was pediatric airway management. And so that should be a continually reoccurring topic. I 100% agree with you.
Dr. Bradley, question for you, if I could. In the education committee, the modules that were mentioned, they cycle and are refreshed every 2 to 3 years to kind of be reviewed and update. Would there be a benefit of PACES coordinating with the education committee and helping out with those rewrites or reviews if we do those on a periodic basis?
Absolutely, that would be a great idea, because I think those are on was just amended today to be a 3-year cycle for review and update. So certainly having the pediatric specific eyes on it, I think is very useful. You know, it's very easy, I think, for the general EMS provider, and even as medical directors, we kind of focus on the adult patient population. So having someone who's really looking for the pediatric specific components would be quite helpful.
Great. And Chris, if you wouldn't mind, if when you have that conversation, you know, that would be the way that PACES gets out ahead of some of those rewrites. Is if we know one of those items, one of those modules needs to be reviewed and updated for a new edition. You know, we have 3 months to work on it. We can get it on the work slate.
Okay.
Thank you, sir.
Adam, this is Shelley. I have a table I can share with you.
Sure. Appreciate it. Well, it might have been enough to help to define what the groups can do and sort of the mechanics behind the groups, and so I appreciate that. Is there any of these items that are specific that anybody wants to provide input on, or want to emphasize more than the other, or it doesn't have to be inclusive of this list?
This is Sandy, and I know I'm not part of the committee, but I'm obviously very interested. I think the patients with special needs, especially those on the autism spectrum, would be very helpful. We get a lot of requests for education on that. And sometimes they are also confused with behavioral health patients, which they are not.
Yeah, I absolutely hear that. I do resonate with that as well. Of the list, I think that would be the one that I would choose as well, Sandy.
Mm-hmm.
I got a little bit mixed up the last time we did this as far as the actual progression to assembling the work group. Am I hearing that we want to assemble a work group to start working on special needs? And
so sorry, go ahead. I didn't let you finish your question. Go ahead.
No, the parliamentary approach. Do we have to make a movement? Do we have to vote on it? Please advise next steps.
So this is written in as a standing item, and is it true that we can discuss or amend or create in any combination of those? Is that right?
Yeah, you can create.
Okay. So with the idea of the standing item was to bring the formation of these groups, you know, the necessity of them and the content of them to the group before we get them going. And then using those work groups as just a mechanism to complete the identified goal or task. So that's really what it's there for. It's not specific to this meeting to formulate a new group. It's there to as a placeholder for discussions about the groups and their topics.
And the option.
We have the option of sort of doing what we want with those groups in these larger meetings.
Okay. All right.
So more or less just a discussion today. Is I didn't really expect much action unless the group wanted to push in a particular direction of one of those topics. But we can start gathering information on the pediatric patients with special needs, there's no harm in that at all.
Yeah. No, I think that would be very valuable. Again, I'm a little hesitant based upon the previous comments to just tackle this right away until we hear back from education.
Right.
What's already there. So, you know, once we hear back from education, to be honest with you, abuse, neglect, I have a slide set that I would donate. And I would send it to you all and we would edit it and have it done pretty quickly, probably. If that's something we want to add to the module. So, so definitely with those two items, number 2 and number 3, I think we should move forward with them. But again, for processing, to not recreate the wheel, however you say it, we'll have that conversation with the education committee and then move forward with them. Does that seem reasonable?
Absolutely.
Dr. Woolrich, this is
Yes,
Ray
sir.
Pro. Sorry, like I said, I just wanted to kind of just real quick bring up, I know these 3 are on here as far as the to discuss and suggestions. Does that mean that this list can't be changed or we can't add to it or anything like that? Or
We can definitely add to it. These are listed as standing items.
Okay.
But I mean, we have a, you know, if at a minimum, call to the public to put them on the docket for us to start working on going forward. Absolutely.
Okay.
That's why we recruited you to our committee.
No, I was saying, I know just the one thing I don't see on there that was it's kind of resonating. I've seen it at NAEMSP, I believe in 21. I saw it at 22 here for First Care First there in Florida. It seems to be a big topic is child bereavement. You know, actually training people in EMS and things like that on how to deal with death with kids, as far as having giving them some kind of formal training, because that seems to be a ticket. I know some actual agencies in Arizona are actually looking at specialty subject matter experts that are dealing in this, such as Alexandra Jobber. I believe she was just did a course for like Gilbert Fire and some other ones where, you know, we're actually having our guys that are actually going there and calling kids on scene, and they have no formal training. So I just see that's kind of like a topic that's been getting spread around the U.S. as a whole is ped bereavement. So I was just wondering if, and there's a lot of information out there from really good people. So throwing a PowerPoint together, I don't think would be that hard.
Yeah.
Dr. Wooldridge, that was brought up at education, correct, Chris?
Oh, okay.
Yeah,
Perfect.
and I was gonna kind of add to that. I sometimes wonder if EMS was more comfortable with this topic, whether that would lead them to be more comfortable with resuscitating the pediatric cardiac arrest on scene rather than this idea of picking them up, transporting them as quickly as possible. And the SEMSO has some very, very good statements on why it's so important that all cardiac arrest victims be seen at the scene as close to the scene as operationally possible, because CPR quality diminishes. And I sometimes wonder if they were comfortable with bereavement and those things, would they be more apt to stay on scene and try to resuscitate pediatric, cardiac arrest victims?
Absolutely. Yeah, Chris makes a great point. That's a huge thing. And it's even going to the point to where we're seeing bigger agencies that are very progressive, actually like, hey, would you like us to attend the child's funeral? Would you like us to do this, sending cards? It just seems like it's a topic that I kind of heard about maybe a couple of years back, and it's just kind of taken off to where we have these people that are, like I said, it just seems like it's everywhere I go, there's always something as far as nationally on that. And to kind of touch on what Chris was saying, as far as cardiac arrest for peds, there are some very progressive agencies that are actually working and doing drills with their ER to where when EMS brings in a child, they're actually running it. And the ER staff is actually standing back saying, hey, what do you need from us? Because they're saying, we have the tools, we have, feedback, we have all this stuff, and we're all trained together to make sure we have the best possible outcome. It's kind of, someone's like, wow, that's actually, and you actually get to see the video of these departments doing that. And it's actually, wow, it's pretty, some of them are very, I wouldn't say radical, but it's very like progressive to kind of see that. It's like, never thought of it that way as far as that kind of stuff. So there is a lot of information as far as like Chris was saying with that too.
One of the statements as the SEMSO is when they're giving supporting, supporting verbiage on why you should resuscitate these victims on scene, is because EMS or pre-hospital the care should be equivalent to that of an emergency department. So it would make sense to me that they would continue care in the ER to have equivalent care of an emergency department.
Yeah.
Well, it's such a multifaceted topic. Chris, you're bringing up important medical management scenarios of appropriate resuscitation, effective resuscitation. And we're also talking about paramedic wellness, the PTSD associated with pronouncing a child in the scene. But you have to flip that over and you have to think about the forensic component to it also. All pediatric deaths, unless they're obviously natural in nature, are medical examiner cases until proven otherwise, which means it's a law enforcement involvement. So there's a lot of forensic considerations. Transport gives you 2 crime scenes. So it's a very broad topic, but I think I think this would be really beneficial to put something together. Sandy, when this was brought up in education, I attended education, but I didn't catch what the intent was going forward. If they're going to start working on a module, then maybe Chris can kind of shoehorn us in there a little bit.
It was on, excuse me, it was on the list of topics that they felt was important to put a work group together for, I believe. After attending all these meetings this morning, they kind of run together.
Yes, this was the work group that was formed with the understanding that death notification, while very important, is a little bit lower in terms of the priority of the work groups that are going to be put together. So the number 1 priority is going to be a training education on the ACS update for trauma triage. So that is a top priority for the November meeting. There was a couple other ones that are also on there, but the hope is that the group would like to start working on a training on death notification for EMS, likely not until beginning of 2023.
Dr. Wooldridge, maybe that's something that this group could begin to work on and assist the education committee that way.
I think it's laudable. I would like to. Again, I think we need to work well with our colleagues. Education, I think we'll have that outreach discussion, and I say we put this on the worksheet. Unless anyone's opposed or we hear otherwise, we can get ahead of it a little bit. It sounds like it's not one of the first ones that education's going to work on. Dr. Bradley just mentioned. I agree. Were there any other topics that people considered something that we could potentially promote or move forward with? Okay, I'm going to step us to our next agenda item. This has actually been on the last couple of meeting items to accept a nomination for a vice chair. And then that would essentially be my partner. It would be a person nominated from the committee who would want to serve in that role. If I couldn't make it or if I fell off a cliff, then that person would be essentially filling my role as the chair. It's a self-nomination. We brought it up the last couple of meetings, and we're still looking for someone to express interest. I'm going to start taking this personally.
Yeah.
Dr. Woolridge, can I have a conversation with you on offline of what this would entail before I commit or nominate myself?
Absolutely, Chris. You bet.
Cool.
Yeah. Adam should probably join us in that. So why don't we do a 3-way?
Sure.
Absolutely.
Maybe in the next week or so.
Is the question, what's the commitment for vice chair?
Yeah.
The commitment to being a vice chair is just chairing the meeting well, if Dale is not unable to attend. So you're basically reading down the agenda. We totally hold your hand and give you chair notes and prompt you and can train you a little bit on how to do the action item. So it's really fun, and I encourage you completely.
Yes,
Those people who have good attendance, yeah.
And as demonstrated by me, you really don't have to understand the parliamentary stuff. You have to have Shelley guiding you.
Okay.
Yeah, well, we totally will help you along.
Okay. Yeah, I'll still have that conversation with you guys offline, and then I'll make a decision.
Okay.
Thank you, Shelley.
Quite ready.
Thanks, Chris.
Pull the trigger, Chris.
I just want to make sure that I can commit to myself, because as you guys know, I've already had trouble as it is, but that's going to change.
Thanks,
Okay, call to the public. Anybody comment, any announcements, anything going on in your community you think was pretty neat and you want to share? Okay, next slide. Go ahead. I heard a mic.
I have a thought. Should we ask for volunteers for the ACS position?
Okay. So I'm going to step us to our next item, upcoming events. Shelley, if you scroll down a little bit further, please.
All right.
And I'll let you just go ahead and read them through. And again, these were in your agenda packet. So be sure to check in on your regional meeting and represent PEDS as you guys go out there. Okay. All right, next meeting is November 17th at 1:30. I think we're going to stay with a remote option, although I think there is an option to come in person. Is that correct, Shelley?
That's correct. We're starting to do the hybrid in-person and online combo.
Great. Unless someone else has something they want to bring up, I will, a couple of seconds, give you guys a minute. Anybody else have anything else to add? If not, I will adjourn us. Can I have a motion to adjourn our PACES meeting?
Mr. Giordano, I'll motion.
Thank you, Jordana.
Second.
Great, thank you so much. Appreciate a great meeting. Thanks, everybody. And we will see you guys.
See you guys next time.
Thank you.